The following podcast is part of a certified educational activity titled Early Recognition and Management of Chronic Heart Failure in the Primary Care Setting. Access the entire activity and complete the post-test at peerview.com/RNV860. Downloadable slides and practice aids are also available.
Hello, this is Dr. Javed Butler from the University of Mississippi. Welcome to this educational activity on the early recognition of heart failure in primary care. This activity will give you the opportunity to explore the early recognition of heart failure in primary care and guide you through the labyrinth of diagnostic and treatment options in some commonly encountered clinical scenarios. This activity is designed to assess and improve our knowledge of strategies for diagnosing and managing patients with heart failure. I'll present a case we can use as a starting point shortly, but here is some brief context on the challenges encountered in treating heart failure in the primary care setting. Firstly, you need to know that heart failure is a commonly encountered diagnosis in primary care practice. Although U.S. cardiovascular mortality trends show significant reductions for ischemic heart disease and stroke since 1988, mortality trends in arrhythmia and heart failure remain unchanged. And mortality rates for all of these conditions is twice as high for individuals with diabetes, which represents about 17% of outpatients visits in the U.S., than for individuals without diabetes. The ACCF-AHA now classify heart failure according to 4 stages, A through D, according to structural disease and symptoms. The staging of heart failure changes the recommendations for treatment, especially the number of classes of medications that are recommended. Because early diagnosis and treatment are associated with better outcomes, it is important for primary care clinicians to be able to screen patients for heart failure and make the appropriate referrals. There have been several updates to the heart failure guidelines. This activity will show you how to apply them to a patient in the primary care setting. Greg is a recent retiree with long-standing dyslipidemia and hypertension and is overweight with a BMI of 28. He's just taking 3 pills a day, one for blood pressure, a statin to reduce cholesterol, and a baby aspirin. Greg participates in recreational league tennis. We don't yet know what his blood pressure and lipid profile looks like. So you have chosen a scenario with a complicating variable type 2 diabetes mellitus and a decision point of an abnormal electrocardiogram. What are some of the features that we should think about in this particular case? 1, is his blood pressure adequately controlled? 2, what are the abnormal ECG findings that will guide us how to approach the management of this patient? 3, is the management of diabetes optimal with the use of linagliptin-metformin combination? Arrhythmias are actually pretty common in patients with diabetes. There's a 24% higher risk among individuals with diabetes to develop atrial fibrillation. Moreover, prolonged QT interval is associated with certain cardiac death, and patients with diabetes tend to have a longer QTc. And also, there is higher risk of certain cardiac death in patients with diabetes that has been reported. A few of the things that can help us in physical examination includes, for example, on auscultation, a murmur, a systolic murmur, or on palpation, maybe the apical beat is displaced from the midclavicular line, 5th intercostal space where it should typically be, elevated jugular venous pressure, or peripheral edema. If you're concerned about the risk of heart failure, either based on symptoms or based on physical examination, ordering natriuretic peptides can be incredibly helpful, BNP or NT-proBNP levels. For instance, if a person has Q waves and does not have history of ischemic heart disease of myocardial infarction, especially in a patient with diabetes, really raises concern for silent myocardial ischemia. If a patient has undiagnosed rhythm disorders like atrial fibrillation, that can give you a clue as to why the patient may have some symptoms or what are the future risks and what are some of the treatment options. What about hemoglobin A1C control in this patient? For a person who is not if frail and at risk for falls, the recommendation is that the hemoglobin A1C should really be less than 7. However, if a person is at risk for falls and hypoglycemia, the guidelines are a little bit more liberal, perhaps a level less than 8. Greg, who is functionally active, has a hemoglobin A1C of 7.8, perhaps should have a tighter hemoglobin A1C control. Which medications should be used for tighter control of his glycemia? The guidelines recommend different strategies based on his baseline cardiovascular status. With all the cardiovascular outcomes trials that have come out, we actually do have agents that have been shown to improve what we call a MACE endpoint, major adverse cardiovascular event, which is a composite of cardiovascular death, myocardial infarction, and stroke. Also, secondary analysis of the cardiovascular outcomes trial and some subsequent trials have shown significant benefit in the risk for heart failure hospitalization and reduction in GFR in these high-risk patients over time. So there is preservation of renal function as well as renal endpoints. The American Diabetes Association treatment algorithm, updated 2019, now specifically mentions that the base therapy continues to be lifestyle modification and metformin. However, for those patients where hemoglobin A1C is not at target with lifestyle modification and metformin, is actually to start stratifying patients based on their atherosclerotic cardiovascular disease risk. And for those patients who actually have a heart failure or a chronic kidney disease phenotype, which is predominant, actually to then start with SGLT2 inhibitors first and then move on to GLP-1 receptor agonist as needed. So as you can see, the guidelines have evolved from glucose-centric perspective, which still remains a very important part of management of these patients, to atherosclerotic cardiovascular risk management. For those patients without established atherosclerotic cardiovascular disease or CKD, there are other options like DPP-4 inhibitors that one may consider. You have chosen a scenario with a complicating variable of stage 2 chronic kidney disease, and the decision point is abnormal electrocardiogram. If you look at the case that we have been following through, we now have the information of glomerular filtration rate in this patient, which is 70 mL per minute. How do you classify a patient across the spectrum of chronic kidney disease? The most common classification scheme which is used is KDOQI nomenclature, which is Kidney Disease Outcomes and Quality Improvement Initiative nomenclature. Greg has a GFR of 70, so it is not more than 90, but it is greater than 60, and has microalbuminuria, so he is G2A2 classification. The risk for both renal outcomes and for cardiovascular outcomes worsen as patients move across either of the two aspects, with worsening GFR or worsening albuminuria, and certainly with the combination of both. Patients with heart failure are at risk for arrhythmias. The problem is, however, clinically, that a lot of the times the arrhythmias may be either asymptomatic or the patient may have symptoms which are not directly attributable to arrhythmias like palpitations, but the symptoms may be non-specific like dyspnea. Patients with heart failure have a pretty high risk of atrial fibrillation. Ivabradine really improves the outcomes for patients with heart failure, reduced ejection fraction in terms of reducing the risk of recurrent heart failure hospitalization. But there is a small risk that these normal sinus patients may go into atrial fibrillation, and that has to be monitored. Similarly, there is also increased risk of ventricular arrhythmias, which may be relatively benign, like premature ventricular contractions, but the place where we get really worried is either symptomatic arrhythmias, syncope, or sustained ventricular tachycardia. Remember that referral to a patient to cardiologist for evaluation for defibrillator therapy is very important for persistent low ejection fraction on optimal medical therapy, irrespective whether you have demonstrated that these patients have ventricular ectopy or arrhythmias. What do the guidelines tell what to do for the management of these patients who has heart failure, who has CKD as well? Well, one is the evaluation, and the other is optimization of medical therapy. We should be particularly careful about abnormal ECG in patients with CKD because patients with chronic kidney disease are at a particularly higher risk of adverse cardiovascular outcomes and cardiovascular disease, especially both subclinical coronary artery disease or subclinical heart failure. Therefore, if you have an abnormal ECG, whether it is Q waves that you see on the ECG, arrhythmias, STT changes, voltage changes, all of those things should really alert us for further evaluation of cardiovascular disease, both coronary artery disease and heart failure. You have now chosen a person with the comorbidities that we have been following, but this person is non-adherent to their medications and has an abnormal electrocardiogram. That abnormality could be multiple different things. This abnormality could be tachyarrhythmias, bradyarrhythmias, pauses, STT changes, Q waves, the amplitude of the voltage of the QRS. All of these abnormalities guide us what are the next steps that we need to take in the evaluation of these patients because these things are associated with varying different risks and varying different evaluation paradigms. So the ECG abnormality is a good positive predictive value, but normal ECG does not guarantee that there's no cardiovascular disease. So we still have to put our clinician's hat and be very cognizant when we are taking history and doing physical examination that any clues make us go down a path of further evaluation of cardiovascular diseases. Adherence to medical therapy is incredibly important. Remember, as clinicians, we are coaches. The patients themselves are the players, and unless and until they play the game, it will be difficult for us to help them improve their outcome. Having said that, remember that lack of adherence is a very, very complex construct. There are disease-related barriers to adherence. Multiple diseases, multiple medications, multiple side effects, all of those things sort of interact, blood pressure, potassium, renal function. So those are some of the reasons that the patients may not be able to take recommended medical therapy. Your diabetes drug and your hypertension drug and your heart failure drug, all of them lower blood pressure and the person already has some orthostatic dizziness. Healthcare related factor becomes very important as well. How much have we taught the patient to monitor patient-related factors? What is their belief structure, whether or not they believe in one way or therapy or not? How much salt is in their food? There are racial and ethnic differences in that respect as well. Older patients, can they come to healthcare or go and get their medications by themselves, or do they need caregivers? Social determinants of health are things that we just don't talk about enough. So things like whether they can afford their medications, whether they have adequate insurance status. Also, what is interesting is that some of this construct related to adherence is actually related to intentional or unintentional factors, and then some of them are the combination of both. So again, as is shown in the slide, a bunch of the things may be unintentional. For example, younger patients with more full lives that tend to spend less time at home, they are working, perhaps they are traveling. It is important as clinicians for us to be at least cognizant of this fact and screen patients for these barriers to adherence. Some of these barriers we may not be able to address, but many of these we are able to address. And if we are not able to address by ourselves, maybe a referral to a social worker, a referral to a nutritionist may help us with our patients. But not addressing these will not lead to improved outcomes for the patients if the patients are not adherent to the medical therapies we recommend to them. What do the guidelines tell us in this particular case? We need to figure out what the abnormality is on ECG and go down a path of appropriate evaluation of this patient, whether it is ischemic issue, primarily arrhythmic issue, or perhaps heart failure issue that is being suggested by the ECG. And the non-adherence really tells us to get some more probing questions in. You have chosen the scenario of a patient with type 2 diabetes mellitus And the decision point is that the patient is complaining that he gets tired easily. The patient who is complaining that they are getting tired easily have a very wide differential diagnosis in general. The American College of Cardiology, American Heart Association guidelines have updated the use of natriuretic peptides, BNP or NT-proBNP, to guide us in such cases for patients who have non-specific symptoms where you are entertaining the diagnosis of heart failure. But another issue is that a lot of our patients may not actually even complain because the patients attribute some of the symptoms to either their advancing age or their weight or a whole host of other reasons. So it is up to us as clinicians to ask questions which are targeted to certain activities and ask them in sort of two different ways. One, are they able to do these things? For example, the amount of physical activity they used to do, say 6 months ago, are they able to do it now? Or the amount of chores that they used to do at home, are they able to do it by themselves, which they used to do by themselves, but now they require some family member or help to be able to do those things. So eliciting those symptoms would be important. Triggers of dyspnea and fatigue are really important for us to elicit. Do the patients get chest pain? What about their exercise capacity and their physical activity? What about symptomatology with sexual activity? What about disordered breathing at night? Fatigue and diminished exercise tolerance can also be symptoms of type 2 diabetes mellitus, or heart failure, or the combination thereof. What do the guidelines tell us to do next? Well, in this particular case, when a person is complaining of being tired easily, one issue in a patient with type 2 diabetes is really to worry about probably undiagnosed heart failure. However, if somebody has gained 10 pounds of weight recently and is getting more short of breath, that's a different scenario. So we have to use our clinical judgment as best as possible. In this particular case, when a person is getting tired or fatigued easily, there are other tests we need to do. This could be coronary artery disease risk equivalent. Should we be doing a cardiac stress test? Maybe we need to do a screening natriuretic peptides. If you hear a murmur or if the natriuretic peptides are positive, this patient may need an echocardiogram. What about uncontrolled diabetes? That is another consideration in this case as well. If a person has acute new onset heart failure symptoms, they certainly need a chest x-ray. A two-dimensional echocardiogram that not only tells you about the diagnosis of heart failure, but other concomitant diagnoses like valvular heart disease or pericardial heart disease can also be diagnosed with that. This slide gives you the overview of guidelines for the management of patients with heart failure. It is worth spending some time on this slide because this will guide many of the therapeutic decisions that we think about in patients with heart failure. You have chosen a scenario where a patient with kidney disease is complaining that they get tired easily. This patient has multiple reasons to get tired easily. They are elderly, they have multiple comorbidities like hypertension and chronic kidney disease. It could be related to the medications that they are taking, or importantly, this could be related to some other undiagnosed diseases, for instance, cardiovascular disease or heart failure. This patient's blood pressure is 123/72, so at least we know that their blood pressure is under control. One, the patient may have symptoms which are non-specific, so further evaluation and history may guide us to hone down to a particular diagnosis. Two, it may help us to look at a broad differential diagnosis. And three, remember, it is very important to ask probing questions because a lot of the time the patients tend to believe that it is related to their age or it is related to their body weight, that they can expect some degree of physical inactivity or exercise intolerance. What do the guidelines tell us that we should do next? What is the next step? Well, one, obviously, we need to know what is the status of control of the comorbidities that we already know. But this new onset of tiredness also opens up this whole host of differential diagnoses that we need to worry about in this patient. this person is at a high risk of cardiovascular disease. So heart failure diagnosis is something which is really important to think about, measuring natriuretic peptide level or echocardiogram depending on your clinical assessment of history and physical examination of this patient. Also, there are other reasons. What about anemia in a person with chronic kidney disease? Maybe iron profile should be assessed in this patient. Also, complete blood count. What about thyroid abnormalities? How do you screen and diagnose patients with iron deficiency? Well, that's where it is a little bit more complicated because the thresholds are different for heart failure patients versus those with CKD without heart failure. Remember that ferritin is an acute phase reactant. Therefore, the thresholds are different in patients with heart failure. Those patients who have heart failure, the threshold is ferritin levels of less than 100 nanogram per ml or ferritin levels 100 to 300 with a transferrin saturation of less than 20. This is now a screening guideline by the ACC/AHA Heart Failure Evaluation and Management Guidelines. This is irrespective whether you have NYHA class 2 or class 3 symptoms. So across the spectrum, broad spectrum of heart failure patients, that the recommendation is to evaluate. This is identical to what the European guidelines are as well. In chronic kidney disease, the recommendation is ferritin level of less than 500 and a transferrin saturation of less than 30 gives you the diagnosis of iron deficiency in chronic kidney disease. You have chosen a scenario where a patient has demonstrated suboptimal adherence to medical recommendation and tires easily as well. So what this case highlights to us is that while we are all very cognizant of medical therapy and giving guideline recommended appropriate therapies, sometimes these non-medical issues of adherence or worsening symptoms on medical therapy, we don't necessarily think hard enough how we can improve upon those symptoms. So for instance, if somebody is not on optimal medical therapy and is not adherent to therapy, whether it is related to patient factors, disease factors, socioeconomic factors, healthcare factors, all of those things need to be addressed. If they're not on optimal therapy, the therapy needs to be optimized. There are multiple cardiac and non-cardiac characteristics that are associated with the clinical syndrome of heart failure. Third heart sound, elevated JVP, orthopnea, edema, ROS. All of these things are specific. Sure, they can occur in some other diseases as well. Some of the medications may give lower extremity edema as well. But in a person with heart failure, combination of these things really makes you worry about further need for optimization of therapy. Then what we need to do is really optimally treat all the comorbidities and not pick and choose one or the other. More than half of the patients with heart failure have depression. About half of the patients are obese. A very large proportion, 1 in 4, have chronic lung disease. Prevalence of coronary artery disease is very prevalent in patients with heart failure. In some studies, it may be in the teens. In other studies, almost 50% of the patients may have coronary artery disease. Arrhythmias, diastolic dysfunction, all of these things are very prevalent in patients with heart failure. So again, the idea here is that when you start developing a management plan for these patients, think about other things that are coexistent that may describe their symptoms partially or fully, or in those patients who have heart failure, if some of these things are present, it tells us either inadequacy of therapy, that we have not treating the patient appropriately so that we need to go up on the doses, or they're not on all the recommended medical therapies and that we need to further optimize the therapy, or look for alternate solutions or alternate comorbidities as well. However, let's take for a second a scenario that a person is actually on optimal medical therapy and now they're complaining of tiredness or fatigue, and they are perhaps even adherent to the therapy. What was optimal therapy at one point is perhaps not optimal medical therapy now. And one big thing in multimorbid patients like this is depression. We don't screen for depression enough. So things like non-adherence, feeling tired, not being able to do enough, some screening for other comorbidities like depression may be very, very important. What about the general well-being of the patient? Well, we can either have a targeted depression screening tool that we can use, or we can use a general well-being tool that was developed by the World Health Organization just to get a sense over time how a person is doing. Remember that the construct of quality of life is related to the perception, the difference in how you perceive what your life should be versus what your life really is. Quality of life clearly is affected by symptoms and by objective measures. So I have shortness of breath, or I have pain, or objective measures that I can walk 30 feet or 300 feet. But the actual definition of quality of life is the difference in the perception of what somebody believes their quality of life should be versus what it is. So these screening tools are very important for two reasons. One, they can target that if they are not doing well, their well-being index is not good, that one, they can target for optimization of heart failure therapy. Two is to look at the diseases that you may not have diagnosed, which may be correlated or associated with heart failure or diabetes or chronic kidney disease. So what do the guidelines tell us for a patient who is poorly adherent and tires easily? Well, conceptually, you can put this person in two different boxes. One is that they get tired easily because they are poorly adherent. So they are not taking their medications, and that's why their blood pressure is not under control. If they have heart failure, that's not optimally treated because they're just not taking the medications, not taking the low salt diet, not doing the exercise regimen that they've been recommended. So all of these things are directly correlated, and in that case, addressing adherence become the central feature of the management of these patients. However, these two things may be correlated. So the first thing that you really start worrying about, somebody who is not doing well, not feeling well, tires easily, have these non-specific complaints, who is not taking their medication, despite of the fact that they know how important it is for them to take the medication, you start really worrying about some other diseases, like for instance depression, that maybe they are depressed. A big overlap between depression and heart failure. Other comorbidities tend to coexist as well. You have now chosen the scenario of a patient with type 2 diabetes mellitus, and the decision point is that the patient has elevated natriuretic peptide levels. This is the patient that we have been following through our journey, and now the natriuretic peptide level BNP comes at 900 picogram per ml. The diagnostic threshold that we use for heart failure is 100 picogram per ml. So as we can see, this person has clearly elevated levels of BNP. Natriuretic peptide levels, BNP or NT-proBNP, are incredibly helpful to assess the diagnosis of heart failure in patients who have symptoms suggestive of heart failure. However, there are certain caveats that we need to be careful about. You're talking about cardiopulmonary resuscitation, cardioversion, myocarditis. It can also be elevated if there is a chemotherapeutic agent given to the patient that has cardiac toxicity. Valvular heart disease, pericardial disease, all of these things can also cause elevation of natriuretic peptide levels. Certainly acute coronary syndromes can do it as well. However, there are some non-cardiac causes as well. NT-proBNP specifically tends to rise with age. Renal failure may be associated with elevated levels. Let's look at the data that suggests why there is a class 1 recommendation for the use of ARNI in patients with heart failure, reduced ejection fraction as a replacement therapy for ACE inhibitors. Recall that we mentioned that now the ACC/AHA guidelines recommend that for new onset heart failure for patient who is naive of RAS inhibitor, it is a clinician's choice whether you want to start with ACE inhibitor or ARNI right away. However, there is a class 1 recommendation that for the vast majority of the patients in your clinical practice today who are on ACE inhibitors and have low ejection fraction, that they should be replaced by an ARNI if they have class 2, class 3 symptoms and persistently low EF. Where does that recommendation come from for reduction of morbidity and mortality? Well, that came from this large trial called Paradigm HF, where 8,400 patients were randomized to valsartan sacubitril or enalapril 10 BID. In this trial, what we found that with the use of valsartan sacubitril, there was a 20% relative risk reduction in the primary endpoint of cardiovascular death or heart failure hospitalization. Now, what is interesting is that neprilysin inhibition and vasoactive peptides have actually impact on glycemic control as well. With the use of valsartan sacubitril in patients who had diabetes in the Paradigm HF trial, there was actually a significantly more reduction in the mean hemoglobin A1C, as is shown in this slide. And the need for new insulin initiation over time was also less in patients with valsartan sacubitril. Patients with renal dysfunction are at a higher risk for adverse outcomes, as is shown in this slide. However, what is also worth noting is that while patients with renal dysfunction are at a higher risk at an absolute level, in terms of the relative benefit with valsartan sacubitril, those with and without worse renal function, both of those groups benefited with the use of valsartan sacubitril as compared to ACE inhibitor enalapril. And across the spectrum of the different therapies that have been tried, there are 3 different drugs within the SGLT2 inhibitor class: empagliflozin, canagliflozin, and dapagliflozin. And the 3 trials declare EMPA-REG and CANVAS. And what we see is consistent reduction, as is seen here on the slide, for the risk of heart failure hospitalization reduction across all the trials and across these various different patient types. You have chosen the scenario of a patient with stage 2 CKD who has an elevated natriuretic peptide level. We have been following this patient's clinical history, examination, and laboratory test, and now we have the information that the natriuretic peptide level BNP comes back at 507 picogram per ml. So it's clearly significantly above the 100 threshold, and I think we should feel pretty comfortable that perhaps this patient has heart failure. However, remember that the evaluation for patients with elevated NT-proBNP or BNP levels will then require an echocardiogram, which will give us more insights into the diagnosis and cause of heart failure per se. But we cannot forget that there are other non-cardiac causes that may be associated with a higher natriuretic peptide level. Advancing age and NT-proBNP levels are very well correlated. Presence of anemia, presence of renal failure, some things which are relevant to the case that we are discussing can also raise the natriuretic peptide levels as well. Although the natriuretic peptide level tend to generally go up at GFRs lower than the stage at which our patient currently is. What do the guidelines tell us when a person like Greg now has elevated NT-proBNP? You are concerned about the diagnosis of heart failure, and therefore you have decided to do the natriuretic peptide testing in the first place. Evaluation of an echocardiogram is definitely the next step for this patient, along with these other considerations. One thing which is very closely correlated with all of these right ventricular abnormalities is sleep disordered breathing. So evaluation with history and in targeted cases with further testing for sleep disordered breathing and obstructive sleep apnea becomes pretty important. There are standardized questionnaires as well that can help you, which incorporates the information both on symptoms and on the patient's medical history. One example here is the Stop Bang questionnaire for obstructive sleep apnea. Depending on the score, 0 to 2, really not high risk, 3 to 4, moderate risk, and anybody who has 5 or more is at higher risk for obstructive sleep apnea. And you can use this screening tool to guide which are the patients you will refer for a sleep study. You have chosen a scenario where the patient is poorly adherent to the medical recommendation and has elevated natriuretic peptide levels. A person who is complaining of taking too many pills. Well, what is the reason for non-adherence? What does taking too many pills mean when the person knows that those pills are important for their comorbidities? Well, too many pills means too many side effects. Too many pills mean that they have some belief system that they don't want to take a bunch of medications. Too many pills may mean that it's just too much cost, that they cannot afford it. So non-adherence is not always behavioral. Let's think about the elevated natriuretic peptide level. This level is really elevated. If this person had known diagnosis of heart failure and their BNP is elevated and the person is non-adherent, you're really concerned about worsening heart failure in this patient, and that this patient is ready to get into the hospital and maybe have adverse outcomes. So further optimizing a medical regimen and emphasizing adherence becomes really important. Let's take a scenario that this person is not somebody who carries a diagnosis of heart failure. Then what non-adherence is doing, that the subclinical heart failure, subclinical phenotype that they may get into heart failure, that phenotype is now clinically evident. So with lack of blood pressure control or lack of diabetes control, now this subclinical type has become clinically manifest, their BNP is elevated, and now we need to evaluate them for the causes of heart failure and appropriately manage heart failure as well. So what do the guidelines tell us? Well, what the guidelines tell us is that we really need to look at this issue of adherence in a more comprehensive way. Maybe it is just simply related to cost. Maybe it is patient-related factor that they don't understand what the need is. Whether it is healthcare-related factor, they cannot come to the clinic as frequently. Regardless of what the reason is for the lack of optimal medical therapy, the lack of optimal medical therapy puts the patient at high risk. And it is not only high risk for things like functional capacity or quality of life, which are obviously very, very important. They put the patients at high risk of mortality. So we are actually talking about the longevity. Obviously, in some patients, it may be related to behavior, but it's a much more complex construct. And unless and until we address that, either we address that or refer to them with somebody who can help us address that, whether it is a social worker, a therapist, a nutritionist, a nurse practitioner, or a dietitian, whoever it is that can help us, but without addressing adherence, it is very difficult. In this person who now has a high natriuretic peptide level, you have pretty much made the diagnosis of heart failure in this person as well. So this person needs evaluation and management of heart failure. One thing they certainly need is a 2D echocardiogram to figure out what type of heart failure they have, whether they have systolic dysfunction or primarily heart failure with preserved ejection fraction. We need to look at other things that may precipitate heart failure. So we need to look at anemia, iron deficiency, look at adequacy of diabetes control, a thyroid function test. All of these things are part and parcel of evaluation of patients who you have just diagnosed with heart failure, chest x-ray, pulmonary status. So comprehensive evaluation of a new onset heart failure patient is really important, some of which may require a referral to a specialist, for example, an echocardiogram or evaluation of coronary artery disease, stress testing, or cardiac catheterization. Adherence to medical therapy is really important because if the patients don't take medical therapy for whatever reason, it may be upon us. Maybe as clinicians, we don't have enough exposure or experience to using the medications, that we may feel lack of self-efficacy to be able to give all classes of medications or all classes of medications at higher doses. You don't get much benefit if you were to use ACE inhibitors and angiotensin receptor blocker together. But barring that exception, which obviously is not clinically recommended, as you add more medical therapies, ACE inhibitors, beta blockers, MRA, 2 out of 3, 3 out of 3, as you increase the medical therapy, there is an incremental benefit in mortality, hospitalization risk with these therapies. Remember, it is still very important to at least give low doses of all medications. In other words, giving high doses of one and not giving at all the other medication is not a good strategy. So maximizing ACE inhibitors and not giving beta blockers at all is not a good strategy. What is a good strategy is at least to give low doses of RAS modulation. So low dose of ARNI, ACE, or ARB, whatever you're using. Low dose of RAS modulation, low dose of beta blocker, low dose of MRA. And then as the patient tolerates, go up on the doses as high as you can. But cover all pathways at the base, give low doses of everything, and then really try to optimize the doses because it has mortality and morbidity implications. For patients who have persistent high heart rate, who are in normal sinus rhythm on optimal beta blocker therapy, a strong consideration should be given for addition of Ivabradine therapy in those patients. When we talk about high heart rate in patients with heart failure, certainly over 100 is a bad sign, but we have a much lower threshold. We're talking about a high heart rate of more than 70. SHIFT trial was a trial that was done in patients with heart rate that was persistently greater than 70 on optimal doses of beta blocker therapy or on maximally tolerated doses of beta blocker therapy. In these patients with low ejection fraction less than 35%, the addition of Ivabradine as compared to placebo showed a substantial reduction in the primary endpoint of cardiovascular death or heart failure hospitalization. Also, this therapy with Ivabradine was tested in patients with coronary artery disease who did not have heart failure in the SIGNIFY trial. So these were patients with stable coronary artery disease. That trial did not show incremental benefit with Ivabradine, but certainly patients with heart failure who are at high risk for recurrent heart failure hospitalization, and these recurrent heart failure hospitalizations are causing a substantial change in the trajectory of the disease with much worse outcomes. There was a 26% reduction in the risk of heart failure hospitalization with the use of Ivabradine in these patients. However, do remember that this is on optimal beta blocker therapy in normal sinus rhythm and not in those patients who have atrial fibrillation.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/RNV 860. This program is supported by an educational grant from Novartis Pharmaceuticals Corporation. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.